Shall we start? Can you see my screen?
Can notice.
Okay, so if at any point you cannot hear me well or the slide is not moving, then you let me know, okay? So today's topic is myofunctional in orthopedic appliances. But we're going to talk about part one, which is the myofunctional appliances. Then the orthopedic appliances, then we're going to talk about the next lectures. So today we just focus on myofunctional appliances. So what's the learning outcome today? So at the end of lecture, you should be able to explain the principle of this myofunctional appliance therapy, then explain the mechanism of actions of myofunctional therapies, then classify the myofunctional appliances, then explain the design, the indication, contraindications, and the clinical scenario in which the various types of myofunctional appliances are used. Then the last one should be able to explain the mechanism of action, indications, and contraindication of various orthopedic appliances, which is the next lectures. So the content of lectures, the first one is introductions, what is myofunctionals, then orthopedic appliances, then definitions, indications, contraindications, classifications, principle of functional appliances, then effect of functional appliances, then the type of functional appliances. So what's the definitions? So myofunctional appliances, it just means a loose fitting or passive appliances which harness or eliminate the natural forces of the orofacial musculature that are transmitted to the teeth and available through the medium of the appliances. So what I'm trying to say is this appliance, you can harness or you can take away the natural forces from the surrounding structures, which is the muscle and the soft tissue. By doing that, then hopefully the jaw will grow into the proper positions. So myofunction means something to do with the muscle and the soft tissue surrounding the bone. So introductions, functional appliances are designed to change the patient pattern of functions, alter the jaw relationship. For example, let's say class 2, then maybe we'll make it less class 2. Class 3, maybe we'll make it less class 3. Of course, class 1, we don't have to modify. So mainly this myofunctional appliance and the orthopedic appliances is designed for the patient have the skeletal discrepancy, which means they have the class 2 or class 3 skeletal pattern. So class 1, we seldom use it. So usually this one is for the jaw discrepancy. So the main function is to try to alter the jaw relationship. So class 2 make it less class 2, then maybe class 3 make it less class 3. So we program the neuromusculature, which is the muscle, thus altering the functional matrix of the face. So I'm not sure you remember during the growth lecture, then we talk about this functional matrix. And this functional matrix, we have the periosteal matrix and then the capsular matrix. The periosteal matrix, you mean whatever soft tissue surrounding the bone, next to the bone. Then capsular matrix is just oral cavity, nasal cavity. So you look at the bottom pictures. So for example, this oral cavity, there are so many muscles around. So we orbicularis, oris, and this one surrounding the lips. The buccinator, which is the side. So buccinator is very important for suctions. Thoracomandibular raphe. Then we have a superior pharyngeal constrictor, then labial pang, then vestibular seal. So this muscle will act to the teeth, and that's the tongue behind the teeth. So all this muscle and soft tissue will act then to get the balance forces, and that's where the zero zone is. So when these teeth move into a stable position, you must get the balance from the buccal and the palatal. So palatal is the tongue, then buccal is all the muscles. Of course, we have the third component, which is the ligament periodontium. So all these three components must act balance to the teeth, then in order to achieve the stable result. So what's the indication for these myofunctional appliances? So the age group then usually it's 8 to 12 years old. Why? Because this group of patients, they grow the fastest, and there's a group people growth spurt. So the mixed dentition period, early mid permanent or early permanent dentition, then with the growth spurt. So for a girl, then we talk about this, about 11 to 13 years old, plus minus 2 years. And our boy is about 12 to 14, again, plus minus 2. So, and this one is specially designed for the class 2 division 2 mouth occlusion, which means the overjet increase, then sometimes with the anti-open bite or sometimes with the deep oral bite. Then skeletal class 2 mouth occlusion with the normal maxilla and retromactic mandible. So mainly we want to move the mandible forward. That's why the maxilla should be the normal size and length. So mainly we target the mandible for this functional appliance. And functional class 2 mouth occlusion, again, the top teeth stick out a little bit. And favorable pattern of direction of growth, average and horizontal. So this one is not aggressive growth, and patients have to have average or favorable pattern. And motivation of the patients, very important. So we ask the patients, what's the concern? The first question when they come in, whenever a patient comes for the consultation, the first question I ask the patient is, what's your concern? So if the patient have no concern, then why we are doing treatment? So sometimes same for the kids, although they're still young. So if the first question is the kids doesn't care about anything, then it's very difficult to get compliance. So the motivation of the patient is very important. Because remember, this myofunctional, most of the time they are removable. Means the patient can take it out and put it back themselves. So if the patient is not motivated, then very difficult to get the patient to wear the appliance. And most of these myofunctional appliance, then you have to wear it at least nighttime. Then if possible, 24 hours or full time, which means the patient have to wear it all the time except when eating or maybe doing some contact sport. So if the patient is not motivated, then no way you can get the result. So the next one is the well-aligned arches. So if there's severe crowding or crowded patients, then it's best to deal with the fixed appliance rather than the functionals. Because functional mainly is just to bring the upper teeth back and the lower teeth forward. So that's because we're using the force on the muscle. So when it comes to rotations or crowding, this myofunctional is going to solve it. So ideally, so this patient, if they have a well-aligned arches, then the best to suit for these myofunctional appliances. Because later, maybe if they come to crowding, we have to deal with the fixed appliances. So upper, lower incisor, so upright, lower incisor. So this myofunctional, they have the side effect is they will proclaim the lower incisor most of the time because of the forces. So you're pulling the top teeth backward, which means you're retrocline the upper incisor, and you're proclaim the lower incisor because you're pushing the lower teeth forward. So there's an inevitable side effect for myofunctional, where retrocline the upper incisor, at the same time the proclaim the lower incisor. So let's say the lower incisor is already proclaimed, then maybe it will make it worse. So ideally, this patient, you have the upright or slightly retrocline lower incisor, which is the best for myofunctional appliance. Then overjet should be 8 to 8 millimeters, which is considered moderate case, moderate overjet. So it comes to severe, which is more than 9 millimeters, then maybe you have to think about orthodontic surgery. So this myofunctional, usually we deal with the moderate cases. So when it comes to severe case, it's still back to orthodontic surgery. So of course, mild case, we can deal with the fixed appliance alone. When it comes to the moderate case, maybe we'll do the myofunctional first to reduce the overjet, then later followed by the fixed appliance, which will make the job easier. So for example, let's say that the top teeth stick out, maybe about 6 to 8 millimeters, then have a retrognatic lower jaw, then maybe we'll put the myofunctional appliance, which is twin block in this case. Then we can pull the upper teeth backward, then lower teeth forward. Look at the incisor angle. You see the upper incisor slightly retroclined compared to the starting situation. Then the lower incisor slightly proclined compared to initial slightly retroclined. So there's a side effect I mentioned just now. So for this myofunctional, whether the twin block or whatever functional appliance, then the side effect is we will retrocline the upper incisor, then at the same time we procline the lower incisor. There's the forces applied to the teeth. And of course, we'll create an open bite at the back, temporary, which is after 1 year wearing. Sometimes 6 to 9 months, depends on progress. But this open bite will settle down after maybe 6 months of nighttime wearing, or maybe you can do an inclined back plane temporary, just to let the bite settle down. So when it comes to myofunctional appliance, then how you know the patient is suitable for the myofunctional appliance? So we try to do this visual treatment objective. We call it VTO. Very simple. So let's say if a patient have a retronatic mandible, which is increased overjet, then maybe you ask the patient try to protrude the lower mandible forward. So when you try to bring the lower mandible forward, then ask the patient to close the lip. So if this is favorable profile, it means patient present a nice profile after the protruding the lower jaw forward, then that might be a good case. So we use a naked eye to judge whether the patient is suitable for the functional appliance. So let's say the patient bring the lower jaw forward, then end up the worst facial profile, then maybe this patient is not suitable for the functional appliances. Or maybe the patient not able to achieve the HH or reduce overjet or competent lips, then this kind of patient maybe is too severe. We have to deal with the alternative surgery. So always we ask the patient to bring the lower jaw forward, then try to mimic the final result and see whether they are looking good at the end of the treatment. So what's the contraindication for these myofunctional appliances? So class 1 occlusions, malocclusion, like I say, we usually deal with the class 2 for myofunctional, then orthopedic most of the time class 3. So class 1 malocclusion with severe crowding, then it's best to deal with the fixed appliances. So because crowding cannot solve by myofunctional. So myofunctional mainly is to move the lower jaw forward or bringing the upper teeth back. But when it comes to crowding, then this myofunctional can solve it. So severe dental alveolar problem in permanent dentitions. This one again, crowding, whatever, infraocclusions, then you need a lot of extrusion, intrusion, then it's best to deal with the fixed appliances. Uncooperative patients. So let's say a patient is not going to be cooperative. I say this one is the removable, so patient can take it out. They can remove anytime if they want to. Should the patient don't understand, they're not keen for the treatment, then it's very difficult to get a patient to wear the appliances. So uncooperative patient, then maybe we have to start to educate the patients. When the patient agrees, then only we start the treatment. So sometimes the patient's parents might give you a lot of pressure. Then you have to learn how to deal with that. You have to tell them, this one is not the parents going to wear the appliances. It's the kid's going to wear it. So if the kid's not cooperative, they are not agree with the treatment, I think no point. Because you can force the kid to wear it daytime. The night time, then the patient always can take it out. Or whenever they're at school, then they're not wearing it, then you get the less result from the patients. Then the last one is adult patients. So we all know the adult patient is not growing. That's why this functional appliance cannot work for adult patients. So myofunctionals only work if the patient is still growing. That's the first principle. If the patient stops growing, then what's the best is orthodontic surgery because it cannot grow the jaw anymore. So jaw modifications only work if the patient is still growing. So what's the advantages for this myofunctional appliance? It enables the eliminations of the abnormal muscle function, thereby aiding in the normal development. Like I say, this functional appliance, you just pull away the muscle, so the muscle cannot give any forces to the teeth, then therefore maybe they're hoping the jaw will develop in the normal conditions. So the treatment can be initiated at the early age. So we know all the fixed appliances usually we put on when the patient have a permanent dentitions, which is about 12 years old. So before that, then usually we wait and see, we observe. But this myofunctional, you can start early. You can start even as early as 8 to 9 years old. and hopefully the patient will get the most out of this treatment. So this functional appliance can be started when the patient is still on the early age. But fixed appliances, then you have to wait. Then the earliest you can start is about 12 to 13 years old, which the patient have the permanent conditions. Then less chairside time is spent because most of the time this myofunctional, they only have a few components, which is the ADAMs, then maybe lady wearable, ADAM clubs, so for retention purpose. So most of the time when the patient come in, what you have to do, you just have to tighten up this appliance, but you don't have to do a lot of activations. Compared to fixed, then you have so many components, the wire, the bracket, then the O-ring, power chain. So you spend a bit more time for the fixed appliance compared to this myofunctional. So myofunctional, most of the time when the patient comes in, then the regular review is to check the overjet, molar relationship, canal relationship, then check the patient compliance. At the end, maybe tighten up a little bit the appliance, then they send patient home. So quite fast, maybe about 10 to 15 minutes, then we are done for the review. The frequency of the patient visit is less. So for fixed appliance, then because you have to constantly adjust the appliances, then you have to change the O-ring or power chain. Then most of the time you call the patient back every 4 to 6 weeks for fixed appliances. But this myofunctional, you can see the patient to the treatment, no problem. As long as the patients keep wearing these appliances, then it will work. Because like I say, you don't have to adjust a lot. Most of the time you just tighten up the retention component. And they do not interfere with the oral hygiene status. So this one common sense. So whenever come to removable, you can take it out when brushing your teeth, so it doesn't interfere with your oral hygiene regions. So when it comes to fix is something stick on the tooth you cannot remove. They will interfere with your oral hygiene maintenance. So you cannot brush your teeth well or full step. That's a very common problem for fixed appliances. The duration of the treatment is comparatively less. So fixed appliance usually take about 2 to 3 years, sometimes 3 to 4 years, sometimes even more than 5 years, depends the difficulty and complexity of the case. But myofunctional, most of the time they take about 1 to 1.5 years to complete the procedure or the case. They deal with the skeletal as well as the dental alveolar problem. Okay, so the myofunctional mainly deal with the skeletal, but sometimes you get some dental alveolar effect or movement. Let's say the upper incisor, maybe retrocline, the lower incisor will procline a little bit. There's a dental alveolar effect from the myofunctional. What's the disadvantages for this myofunctional? The appliance is bulky because there's so many pieces on top and bottom. Then they have certain height, then they have a block. So this one can be quite bulky. And the cooperations of the patient is essential. When we come to removable, then patient compliance is essential. They cannot be used in adult patients where the growth has ceased. So when the patient has stopped growing, then we cannot use this. This one we mentioned this. Cannot be used to bring about individual tooth movement, and in the case of crowding. So you see this myofunctional, they move the teeth in the block. They move the upper jaw backward, then lower jaw forward. So they're moving the teeth in the block. When it comes to individual movement, let's say you want to intrude, extrude, move the teeth labially, buccally, crowding, rotation, then this one only can be done by using fixed appliance, or you have to use a jack spring, T-spring, like you bent in the lab before. So whenever it comes to individual tooth movement, then it's best to deal with the fixed appliances. So fixed appliances therapy may be required at the termination of the treatment or the final detailing of the occlusion. So if the patient started with this myofunctional, then doesn't mean they can avoid the fixed appliances. So sometimes, even though we bring the teeth back, so let's say we settle the overjet, overbite problem, then patient have the crowding or spacing problem. So maybe after the functional appliances, then patient still have to start the fixed appliance to final detailing the occlusion. So sometimes this myofunctional is just the first phase of the treatment, then followed by the second phase, which is the fixed appliance to tidy up the occlusion or to make occlusion perfect. So classification, there are so many classifications. the old timer, we have this Tom Grapple, and they have a group A, which is the tool or the T supported appliance. Then we have a Catalan's appliance, inclined back plane. This one only bind with the T. So this one you see they're resting on the T, but they're not resting on the mucosa. So this one considered group A, only the T supported. Then we have group B, the T and the tissue supported. It means the T and the soft tissue, which is a gum or gingiva. We have the activator or bionator. See this one? We have a component which is labial bowl, rests on the T. Then also have the plastic. So this is plastic on rests on the gingiva. We have a group C, which is a vestibular positions appliance with isolated support from the tube or the tissues. So we have a flanker appliance, which the main active component is the buccal shield or the labial front. So this one will pull the muscle away from the T. Then this one to let the jaw grow into a better position. So this one they're using the T for retention, but the main active component is a buccal shield. So this one considered vestibular position appliance with the isolated support from the T and the tube and the tissues. But recently with the advance of the technology, we have this fixed functional or semi-fixed functional. It means certain component, if fixed on the tube, you cannot remove it. So we have this new classification arrived after this fixed functional appliance invented. So then after this fixed functional appliance invented, then we have the new classification, which the first group is a removable functional appliance. Still the same, activator, bionator, whatever can be removed, top and bottom pieces or one pieces, they're considered removable. Then we have the second group, which is a semi-fixed functional appliance. It means half of it removable, then half of them is fixed. So you see this Dynamax appliance, then horse, base appliance, this one all considered semi-functional, semi-fixed functional. So you see the top component. So this one is a Dynamax appliance. So you see the top component. So this top appliance can be removable. You can remove it and put it back himself. Then this lower or the mandible, this is a lingual arch. So this one is fixed with the molar bands. This one cannot be removed. So we have the top, which is removable. The bottom is fixed. So they consider semi-fixed functional appliance. The top one removable, the bottom is fixed. Or sometimes reverse, whichever come to fixed and then removable mixed together, we consider second group semi-fixed functional appliances. Then we have the third group, fixed functional, which means the top and bottom both also fixed, cannot be removed. Then we have the herbs, which is classic. Then Jasper, Jumbo, Curio, Jumbo, Forces, Power Scope. All this is just function like a piston or spring. So whenever a patient bite together, right, then we'll push the mandible forward, then the maxilla backward. All work the same principle, but some are a bit more rigid than the others, some a bit more flexible. So it depends on the design. So this one is a Forces, I think this one, no sorry, this one is herbs, then this one is Forces, then this one is a Power Scope, this one is a Jasper Jumbo. So there's so many designs, but all work the same. We're just pushing the lower jaw forward, then pushing the upper jaw backward. So we have a classic one, which is about Profit. Profit considered the modern fathers of the orthodontics. So this one, Profit is already passed away, I think, the last couple of years. But his book is still remains. We call it the Bible or orthodontic. If you have chance, then maybe you go through the Profit's books. Then they call it contemporary of orthodontic. So Profit classified this myofunctional into two groups, whether they are tube bone or tissue bone. So the tube bone then is classified as activator, then tissue bone can be Franco regulator. So tube bone, simple, rests on the tube, then tissue bone, it just rests on the soft tissue. So the principle of myofunctional appliance therapy is by constructing a removable appliance that effects a protrusive bite when the appliance is placed in the mouth. So whenever you place this myofunctional appliance in the mouth, so the same principle, they will bring the lower jaw forward. Then hopefully by creating the force from the muscle will pull the top teeth back, then the bottom teeth forward, or pull the upper jaw back, then lower jaw forward. But this is the old definitions. With the new fixed functional appliance, it's a similar, but it's a fixed appliance. It's not removable anymore. So this one should be the old definitions, but the new definition is the same, but it's a fixed appliance. But the same thing, the effect is the same. It's a processive bite when the appliance is placed in the mouth. This one, whether they are fixed or removable, all work the same. So these functional appliances, when you put it in, then it increases the contractile activity of the retropterygoid muscle, then intensifications of the repetitive activity of the retrodiscal pack, which is here. So it's behind the TMJ, then increase in the growth stimulating factor, some cellular changes, then change in the condyle trabecular orientations, then additional growth of the condyle cartilage. So there's a cartilage, then it will grow backward a little bit, then additional subperiosteal ossification of posterior border of the mandible. Then hopefully at the end, that's what we're targeting, is to get a supplementary lengthening of the mandible. It means whenever they position this condyle forward, then hopefully the condyle will grow at the back surfaces, then you get the elongation of the mandible. Same, this is just a summary. You see, whenever patient posture the lower jaw forward, then the condyle will come to this articular imminent fossa. So hopefully this one, the end, the condyle will go back and longer, go backward and upward. At the end, we get this elongation of the mandible. Of course, there's some remodeling of the articular eminence and the fossa also. So modification of the soft tissue, then a lot of time, when the patient have the increased overjet or the shorter lower jaw or mandible, then patient always have this lip competency problem. It means the lip is not competent. So after the modification of the soft tissue, after you bring the lower jaw forward, then hopefully you can get a better lip competency. Then changing in the facial muscle balance, the shield, the screen, this one is the functional appliance. Then the teeth can erupt into the position of the balance. So whenever you take away these muscle forces, then hopefully the teeth can erupt in their better positions. So the first myofunctional appliance we're going to talk about, which is the activator. So this one is considered the oldest activator or the myofunctional appliance. So started by this Anderson, it's the original design. So they have a bite jumping. The concept is a bite jumping. It means they'll bring the lower jaw forward, jumping the bite. So Anderson modified the Hawley retainer, so which is already known as Hawley retainer. They usually have the labial bow plus the Adam clubs. Then in the maxillary arch, to which he aided, then the lower lingual horseshoe-shaped fronts, which will help to position the mandible forward. So you see the same principle applied. You just position the lower jaw forward. Then hopefully you can pull the upper teeth backward, or you can move the mandible forward. So it's a biomechanical working retainer. So it's the same. It's just a retainer with an extra plastic, then position the lower jaw forward. So this one we call it activator. So there's a lot of disadvantages for this activator. So the component of this activator, they're monoblock. It means they are one piece. So upper and lower acrylic appliances fuse together. So cannot be removed. So top and bottom in one piece. So it can be made of cold cure or heat cure. We all know cold cure is a bit more fragile, and heat cure a bit stronger. So of course the cold cure will be easier to fabricate. Then the heat cure will take a bit more time because you have to cook the appliances. Then labial bow is a 0.9 millimeter stainless steel wires, which are a bit thicker than what you're bending. So if you think whatever you're bending now is difficult, then this 0.9 stainless steel wire is going to be a nightmare. Then lower incisor capping. So you see this one, have the lower incisor capping. So this plastic will rest on the lower incisor edges. So that's how it looks like from the front view. So it have lower incisor capping, then plus a labial bow on top. So what's the indications for this activator? It can be used for the class 2 division 1, class 2 division 2, malocclusion, class 3, class 1 open bite, then class 1 deep bite for post-retention treatment. So sometimes if the class 2 skeletal pattern, then after the debond, then we will worry about the relapse of the overjet, then maybe we can put this activator as a retainer. What's the contraindications? It's a correction of the class 1 problem of the crowded teeth, where there's a disharmony of the tooth size and the jaw size. So class 1 problem with the jaw and the tooth size problem, it means the crowding and spacing. Like we discussed before, it's best to deal with the fixed appliance. So cases with the lower proclinations, so I think I mentioned this before. So myofunctional, so a lot of time we procline the lower incisor. So if you started with the lower proclinations, you don't want to procline the lower incisor further. That's why you don't use it for the procline lower incisor cases. So nasal stenosis, which usually patient have the nose blockage, then this case, this kind of patient is not suitable. Because imagine, if you put this activator in the mouth, the patient have to close the lips. So if the nose blocked, then patient cannot breathe. Patient will die. So with the nasal stenosis, then the best to refer the ENT surgeon to deal with the nasal problem first before we start this myofunctional. Non-growing patients, this one we talk about this. Myofunctional only work for growing teenagers or adolescents, not for adult patients. So what's the advantages? So we use the assistant growth. So this jaw or growth modifications appliances, we use the assistant growth. So minimum oral hygiene problem, because it can removable, you can remove it to brush your teeth, so not interfere with your brushing. Appointment usually short. This one we talk about this. Then disadvantage is require good patient cooperation. This one also we mentioned before. Then cannot produce a precise detailing and finishing occlusions. So when it comes to precise detailing and finishings, you need to fix appliance. So how are we going to construct the bite for this activator or myofunctional appliances? Very simple. You just ask the patient to position the lower jaw forward, then you take the bite in this position. So intermaxillary wax record to relate the mandible to the maxilla. Then the teeth out occlusion, it means they are not biting. You're not biting at the posterior segment. So mostly patient only biting on the anterior segment. So it means they have the edge-to-edge incisor, or sometimes they have an open by the posterior, which is okay. That's what we're targeting for. The posture of the lower jaw forward, the facial musculature or muscle is stretched and the forces are generated. So this one is the principle of myofunctional. You position the lower jaw forward, then hopefully the muscle will generate the forces, then pull the upper jaw backward, lower jaw forward. The increased muscle activity acts as a stimulus for the mandibular condyle growth. This one also we talk about this. So this one I just summarize how we take the bite. So first, you take a wax, which is a U-shape or horseshoe shape, then the thickness may be about 7 millimeters, or maybe 8 to maybe also 1 centimeters. It means a thick wax. Then you ask the patient to push the lower jaw forward, which most of the time they only touch on the incisor, but posterior have an open bite. It's okay. You ask the patient to keep practicing this position for a few times. Open, close on this position. Then after that, you put the wax in. Then ask the patient to bite according to the position practice just now. Then you get the bite at the end. So what's the management of the appliance? Then myofunctional, maybe, because it's difficult to get the patient compliance, then maybe you can start gently, then maybe ask the patient to wear it 2 to 3 hours per day for the first week, then slowly or gradually increase the hours of wearing. Then nighttime they wear from the second week, then maybe full time after that. So they record during the 3rd week. So this one, I think we have a lot of arguments. Some specialists or some general practitioners, then they prefer to start the patient with the full time right from the beginning. Because whenever you tell the patient to start maybe 2 or 3 hours, then they'll take it for granted. Maybe they're not wearing it. But if you tell them the full time, start from the beginning, then maybe you can get half day or few hours wearing during the daytime. So this one a bit of psychology strategy. So I think this one I leave it to you. There are some people who will start with half-time or part-time. There are some people who will start with full-time straight right from the beginning. Then they recall during the 3rd week or 4th week, which is usually 1 month later, just to check the patient compliance and how they are doing with the functional appliance. So the second type of myofunctional is Bionator. It's given by this Bauter. It's 1960, which is about 60 years ago. So the bulkiness of the activator and its limitation to nighttime wear lead to development of Bionator. So you see this activator, like we say, the design is in one piece. So in one piece, then every time the patient wear it, then they cannot talk. When they open or there's separation between the top and bottom teeth, then this appliance will drop. So that's why patient only can wear it nighttime. Compared to this Bionator you can wear it almost full time. So the principle of Bionator is not only activate the muscle, but to modulate the muscle activity, thereby enhancing the normal development of the inherent growth pattern. So you see this Bionator, they not only position the lower jaw forward. Look at these wires on the buccal. So this one will push the buccal or the buccinator away. So the muscle is not acting on the teeth. So this is not only activate the muscle, but also modulate the muscle activity, which is on the buccal side. So hopefully you get more effect from these myofunctional appliances. So this functional appliance or Bionator, they also have the palate component or palatal component. The palate is free from the proprioceptive contact with the tongue, and the buccinator wire loops hold away potential deforming muscle actions. So you see, this buccal side, they have this wire which is prevent the buccinator acting on the teeth. On the lingual side or the palatal side, they have these loops. This loop will prevent the muscle from the tongue to act on the teeth. So you got two components. So if you take away the buccal and the palatal forces from the soft tissue of the muscle, then hopefully the teeth will develop in the better positions. So according to Bauter, the equilibrium between the tongue and the circumolar muscle is essential for the normal shape of the dental arches, and the functional space for tongue is essential for the normal development of the orofacial system. So abnormal position of the tongue lead to the development of the malocclusions. So you see the current literature. Is someone eating? It's okay. So the current concept is the tongue position is very important. You see the tongue can decide the crowding and the expansion or developments of the maxilla. So let's say you put the tongue in the wrong position for a long time, then maybe the patient will develop malocclusions. So abnormal position of the tongue can lead to development of malocclusions. Then class 2 positions displacement, posterior displacement. Class 3, the low anterior displacement. So if the tongue is a posterior displacement, then maybe have a class 2 malocclusion. Then usually if the tongue is displaced low anterior, it means the tongue is a bit lower than the normal position, then we develop a class 3. So narrow arches and the crowding is a low outward pressure. Then the open back is hyperactivity and the forward posture of the tongue. So you see the tongue can create so many problems. So let's say if you train the tongue right from the beginning, then maybe you can help the patient to develop a better two positions. So the aims of treatment is to accomplish the lip closure and establish the contact between the back of the tongue and the soft palate. So they train the tongue, enlarge the oral space, incisor to edge to edge, elongation of the mandible. Then hopefully, this is what we are trying to achieve, leading to an improved relationship between the jaw, the tongue, the dentition, and the soft tissue. Everything will live in a harmony. So what's the indication for this Bionator? It's a well-aligned dental arches, like we say, this functional appliance or myofunctional appliance. They are not going to align the teeth. Most of the time, they're just pulling the top teeth back, then moving the bottom teeth forward. But crowding, we have to deal with the fixed appliances. So functional retrusions, when we come to a short mandible, then maybe we can use a Bionator to move the mandible forward. Mild to moderate skeletal discrepancy, so we can deal with the myofunctional. When it comes to severe, then we deal with the orthodontic surgery. No evidence of the labor tipping seen. So that's how we say about this labor tipping or proclination of the lower incisor. Then when we come to this myofunctional, we try to. Can someone off the mic? I think it's some noise from someone eating. I don't know. Yeah, there's no evidence of labor tipping. So if the proclinations already happen, then you have to be careful, because this myofunctional will further tip the lower incisor forward. Contraindications, class 2 relationship is caused by maxilla pronaxium. So it means the maxilla is a problem rather than mandible. So myofunctional mostly we deal with the mandible rather than maxilla. So when it comes to maxilla, which is longer, then maybe we deal with the orthopedic appliances. So vertical growth pattern, labially tip lower incisor. This one I'll talk about this many times. So what's the advantages? Less bulky compared to the activator, which is very bulky. So Bionator is a bit slimmer. Can be worn full time compared to activator, which can wear at night time. Except during the meal. During the meal time is difficult. So far, I think only twin block can be used during eating. Then constant influence on tongue and the perioral muscle. Can someone off your mic because it's interfering with my lectures? Yeah, can you check your mic? Just kindly wait on it. Okay, now we come to the final design, which is twin block appliance. This one is most commonly designed used in Malaysia and the United Kingdom. So this one I like it the most because they're simple, they work perfectly for the patients, and there are two pieces, not like activator and Bionator, they are single piece. They're very difficult to fabricate, and whenever it comes to breakages, very difficult to rectify or repair. Compared to twin block, because there are two pieces, the mandible and maxilla, you can repair it separately. So these twin block appliances, introduced by Williams Junior Clark. Then by 1977, as a two-piece appliance resembling the SWAT, double plate and the sleeve activator. So of course, when they invented, then there are a lot of shortfall for this appliance. Then later, they modified the design again, 1982, 1988, 1995. Then they come up with a better design. Then after that, there's so many dentists modify this twin block appliance according to their own need. So replacement of the occlusal inclined planes by the means of the acrylic inclined planes on the bike block. So look at these pictures. So they just cut this block. Initially it's one piece. Now they cut it into two pieces, one for top and one for the bottom. Then whenever you bite together, then you bring the lower jaw forward. Then using this inclined plane or bite plane, this inclined bite plane will lock the lower jaw forward. That's why you have to have certain angle between these two blocks. We're going to talk about this later. So the mechanism of actions, pay attention to this slide, very important. So you guide the mandible downward and forward. So we all know the mandible is growing downward and forward, same with the maxilla. So they guide the mandible downward and forward. Hopefully the mandible will grow longer. Favorable proprioceptive contact of the inclined plane. So this one will work fine. So you don't have to sacrifice your jaw movement. Your jaw still can move freely, but every time you bite together, then the block will lock the lower jaw forward. Adaptation to the muscle of mastications. So it doesn't the favorite muscle, the tongue, the vaccinator still can work well. Vertical and transverse control. Sometimes we can do the expansions using the expander on the upper or lower. We can expand the jaw separately. So the mode of actions, so rapid neuromuscular response and the gradual dental alveolar response. So we get a bit of neuromuscular response and a bit of dental alveolar response. Then pterygoid response, pain when retracting the mandible. So polyfrications or connective tissue and blood vessel, this one we talk about this. Uploading, unloading the condyle. Discomfort on the removal appliance due to compression, tension zone behind the condyle. So wherever we put the myofunctional in the mouth, because the posture, the lower jaw forward, then the muscle will stretch and create forces, then will cause pain and discomfort to the joint. So the design of the plans, so this is the original design. We have the midline screw, which is for the expansion of the upper maxilla. Then we have the upper lower delta cups. Then we have the labial bowl. Then provisions of the extraoral tractions. So sometimes the upper maxilla is a bit too long. We can put a headgear, they pull the maxilla back. So they have a provision of extraoral tractions. So headgear tip when indicated. So we can put a headgear tip, which is a buccal side of the Adam clubs. You can solder a headgear tip. So you can put a headgear extraorally. So to get the better result. So the design, the main design or the main component for twin block is the block. So we have a cruiser by block with the inclined plane. So we can about 70 degree, this angle. So these two block is the main component for the twin block. By its name, twin block means the block is the most important component. So the midline screw for expansion. So this midline screw every turn will get about 0.25 millimeters expansion. So every time you turn this screw, then we get a bit of expansion. So you keep turning this screw, they will expand the maxilla. So retentions come from Adams or the delta cups, the interdental ball ends clubs on the lower incisor. So all this is for the retentive component. Then labial bowl on the upper incisor, you can use a continuous, which you bend in the lap before. So we can have a split also. It means we can have a cut in the middle. Then it can be active or passive. So if you want active, then you just crimp these U-loops a bit closer to each other. Then you can bring the upper incisor backward and closing the gap. So it can be passive or active, depends on activations. The spring to move the individual teeth, then sometimes we have a jack spring. Then this one also, you know how it works. It's by pushing the teeth labially. Provisions of the extraoral tractions, these are optional. So let's say you think the maxilla is a problem, then maybe you can do the headgear to pull the maxilla backward. So this twin block, to move the mandible forward, and at the same time you can put the headgear extraorally, then you pull the maxilla backward. So delta clubs, similar to the Adams, just that the design is a bit different. But all these delta and Adams work the similar way. They go into the undercut, mesial buccal, and distal buccal side. So I think during the wire bending exercises, I think I taught you not to bend too middle. This arrowhead must be distal or mesial, so you can go into the undercut. So the area of retention is the mesial and distal undercut, interdental undercut, used only on the first or premolar, first molar or premolar. Sometimes you can use on the decidus also, not necessarily permanent, but most of the time we use on permanent molars and the premolar because they are stronger than the decidus. But when it comes to mixed dentition, sometimes no choice, and we use on the decidus also. So the base plate again, we have two, co-cure, he-cure, we talk about this. Then occlusal inclined plane, this one is the most important component. So without this block, this appliance is nothing. So you have to pay attention to this block design. You see the angle between the block must be 70 degrees, which is quite stiff. So if you're less than 70, then maybe the jaw can bypass wherever you ask the patient to bring the lower jaw forward, then this jaw can slip back, so it bypasses the block. So the block must be stiff enough, which is about 70 degrees, then to lock the jaw forward. Of course, you can do 90 degrees, but 90 degrees maybe patient cannot open the mouth because 90 degrees will lock the jaw forward permanently maybe. So 70 degrees is okay. Stiff enough to lock the jaw forward, and when you open, then it's not causing any difficulty. So same thing, fabrication. So once the bite is taken, we should discuss how to take the bite, is transferred to the articulator. So this is again mounted on the fixator, which is mounted articulator, then fabricate according to these positions. So of course, you bend the wire component, then after that it wax up, just like what Eugene taught you in the lab. Then this is followed by the flasking, de-waxing, packing, and curing. So this one can be co-cure, key cure. Then the cure appliance is then polished and finished. So check on the models, proper fitting, and before you fit in the patient's mouth. So what's the advantages of this twin block over the other type of myofunctional appliances? So the functional mechanism is similar to natural dentitions. So you see the myofunctional, we talk about activator, bionator, they're all in one piece. Compared to twin block, which is two pieces, which have a maxilla and mandible. This is quite similar to your natural dentitions. So you're not compromising the jaw movement and talk and the speech. So these patients feel more comfortable with the twin block. So the occlusal inclined planes then give the greater freedom of the movement in the anterior and the lateral exclusions. Your jaw can move anterior, move backward, forward, no problem, because there are two pieces. Less interference with the normal functions. This one we talked about before. Improve the appearance and the function due to the absence of lips, cheek, and the tongue pack. So compared to the other functionals, then sometimes they have this labial pad, then the wires on the buccal shield or frangle, they have a lingual and buccal shield. So this one interfere with the muscle. So these twin blocks is only the block, bringing the lower jaw forward. So they improve the appearance. So if you have a buccal shield, then they are quite bulky. Aesthetically acceptable. So this one, I think I have a different opinion. So the twin block is not aesthetically acceptable. So although they might look better than the others because there are two pieces, but they still consider acceptable to certain kids because when you increase the vertical height, then there's something inside the mouth. The patient will look like a goldfish. So this one we call it goldfish appliances. So sometimes patients when they're wearing it, because they have to increase the vertical height and position the lower jaw forward, sometimes they look quite horrible to the patients. So it can be 124 hours. So because there are two pieces, so no problem for eating and talking. So it can be 124 hours compared to a single piece. So sometimes you open the mouth with a drop, then maybe patient only can wear it at night time. So independent control over the upper and lower arch. So two pieces, you can do separate movement. So for example, you can put a jack spring on the top, you can put a finger spring on the bottom. You can do separate movement with two pieces of appliances. So then finally we come to this frangle regulator. So frangle, they have a different concept. They say the mouth occlusion is caused by the tongue and the buccinator or the muscle or circumferential muscle. So they want to take away all these forces. So soft tissue bone appliances, they're good in mixed dentitions. So good when soft tissue significantly contribute to the mouth occlusion. So if you take away all these forces, then hopefully the jaw and the teeth will develop in the better positions. So the type of frangle appliance, there are so many designs. There are frangle 1, 2, 3, 4, 5. Then they deal with different mouth occlusions. So the acrylic part, we have the vestibular seal. So this one will block the buccinator or circumoral muscle. They have the lip pack. So sometimes we have to get the lips away from the teeth, so the teeth is not being pushed by the lips. So let's say for class 2, then the lip pack usually on the lower. If for class 3, then the lip pack's on the upper. Depends where you want to block the lips. The wire component, you have a palatal bowl, labial support wire, lingual bowl, and canine loops. So you see from the top, then this fungal appliance, then trying to pull away all the muscle from the labia and from the patellar side. Then we come to these fixed functional appliances. So just now we talked about removal, we have single piece, double piece, or we have a fungal which block away the muscle and the soft tissue. Then we have the last one, which is a fixed functional appliances. So this one is a bit later design. Then rigid fixed functional appliance started by Herbst, is a famous orthodontist. Then mandibular protection appliances. Then forces fatigue resistant device. Then non-rigid, we have a bit more flexible, like spring, adjustable jumper, adjustable bite corrector, ABC. Sorry. Then the indications, we have the post-adolescent patients. Let's say the patient already passed the pubertal growth spurt, which is about before 14. For girls a bit early, for boys a bit later. Let's say already past the pubertal growth spurt, it's still growing, but not much. Then maybe we want to catch up whatever we lost before, then maybe we put the fixed functional, just trying to catch up the growth a little bit. So usually for post-adolescent, then maybe we put the fixed functional appliances. So uncooperative patients, because this one is fixed, patient cannot take out, so we take away the compliance. So patients who do not respond to removal functional therapy, let's say they doesn't respond well to the removal, then maybe you give the patient a last chance. Then we put in this fixed functional appliance. So many design, like we showed in the picture before, we have Herbst at one sink, Jasper jumper, forces, power scope, all work by the similar principle. That pulsing lower jaw forward, then hopefully this appliance will bring the upper maxilla backward, lower mandible forward. Okay, I think orthopedic appliance, we'll talk about this for the next lectures. Do you have any question to ask me for these myofunctional appliance? No questions? No questions? If no questions, then maybe kindly sign your attendance before you leave. Then I'll see you next week. Are you all still here? I assume there are no questions here. Right?
Yes, Doctor.
Okay, I'll see you next week.
Thank you, Doctor.